No, sir.
Hmm? Any other question?
I didn't understand that, sir.
No, sir.
Part.
No, sir.
Yeah, is that your questions is clear?
Hello?
Yeah. Is your question is clear?
So voice is breaking, sir.
Whose voice is breaking? Huh? Is it clear?
Yes, sir.
So we'll move to the other slide.
Yes, sir.
Okay. Yeah, I
Yes,
given
sir.
any questions earlier. Huh? Hello. Hello.
Hello?
Yes. Did I give some questions?
Your voice is breaking, sir.
How about now?
Yes, sir.
Now it's okay.
Okay. Any questions I given last class?
Again.
Yes, sir.
What was the question? Yeah, tell me what was the questions?
Enteropathogenic, enterotoxigenic, enteroinvasive, enterohemorrhagic. Examples and explanation.
Oh, that was toxicology, no?
Yes, sir.
That is for
Yes, sir.
toxicology.
It's for toxicology, yeah. Okay. Therapeutics, anything I gave?
No, sir.
No, sir.
No, sir.
Okay, I will give now, take the questions, few questions. Okay, list the drugs that induces sleep.
Hello?
Yes.
Citrus.
Sir,
Huh?
what, sir? I couldn't get you.
List the drugs that causes sleep, that induces sleep.
What, sir? The causes? I didn't get you.
That causes sleep, induces sleep as a side effect, adverse effect. Got my question?
No, sir. Your voice is breaking
Aaron,
somehow.
list the drug
No, sir. It's
that
clear.
induces sleep.
Yes.
Sleep. Okay, okay.
Okay.
Yes, sir.
Same, the second question is list the drugs that causes insomnia, that is sleeplessness.
That causes?
Insomnia, sleeplessness. Okay, so you have to list the drugs which causes sleep and drugs which does not cause sleep. That is causes insomnia.
Okay, sir.
Okay.
Yes,
Yes,
sir.
sir.
So we'll move to the next slide. This is again the physiological characteristics of sleep and wake states, where what we have seen at the different stages. So the EEG will cleanly capture the waves. Okay, so in the wake, we can see that the fast and low voltage are seen, and in the non-rapid eye movement, slow high voltage is seen, and in the REM, fast low voltage is seen. And the same way, if you see the eye movement, in the wake vision related, depending upon the vision, the NERM is slow. It is very irregular, the eye movement, because you are still in the different stages. And again, in the REM, it will be rapid, even though you are in a subconscious level, you will not be knowing it. Okay, so rapidly the eye movement will be there. That's what we call as rapid eye movement. You will not be aware, or you will not be knowing it, that's all. But if you see the muscle tone, it's fully double plus here, because you respond to the reflexes and all those things, and the muscle tone will be there. So anytime, any walk, anything, running, anything, it can be done easily. In NRM, you can see that the muscle tone is decreased than the wakefulness. You can see only 1 plus here. And interestingly, if you see that rapid eye movement, okay, I don't know, this everyone could also experience when we are in any kind of like dream, or any weird dreams are there, like we have to run away and go that, and our body, we feel like our body is fully not responding at all. Okay, we feel like cannot do that, so it will be like the muscle tone will be nil here in rapid eye movement. So that's what we say, that the muscle tone, and you can see neuronal activity also, where in double plus is there, and non-rapid movement and eye movement will not be there. So in rapid eye movement, even if you are been for few minutes in rapid eye movement, you will get a lot of relaxation. Okay, so because of there is no muscle tone and neuronal activity, it will be fully nil. So during that time, the muscles and neurons will get a lot of rest because of inactivity. And other heart rate, blood pressure, respiratory rate will be variable in wake, and here is slow, very low. This also, it's variable, higher than non-REM little bit, because you will be in other world, you will be dreaming something there, some thoughts and some process will be going on. So it could be higher than that, than REM. Then responses to hypoxia and hypercarbia is there, very active. Reduced responsiveness and lowest responsiveness is seen in REM. Whereas thermoregulation and mental activity also, in here the behavioral physiological regulation only, and reduced physiological regulation, thermoregulation in the REM. Whereas in the mental activity, its wakefulness is full, non-REM is none or limited, and it is story-like dreams, especially in REM. So that's why mental activity will be seen in REM only, not in non-REM, because you will not feel dreams in non-REM. Is that my voice is clear?
Yes, sir.
No, sir. It's breaking.
I think you have some good network problem, huh, Sharon? Always you only will.
Yes, sir.
What about others?
Yes, sir. Yes,
Yeah,
sir.
it's
It's
clear,
clear,
sir.
sir.
Clear,
It's
sir.
audible, sir. It's clear.
Then you should check your audio system.
Yeah,
Yes, sir.
yeah, problem.
Then I'll
No,
keep
sir.
you.
Huh?
Yes, sir. Okay, sir.
Now it's
I don't know
okay.
what is. Yeah, now it is clear.
Okay. See, when you are not hearing, let me know. If anything from my side, I can adjust, I can do it.
Okay, sir.
Earlier, even if you talk little bit away from laptop, it used to take. Now, I think even the laptop has become more. This one I feel.
Yeah, lockdown mode, sir.
Okay. So coming to the assessment, you know that a lot of assessment has to be done while evaluating the sleep disorder. It's not because it's more of a subjective feeling. We cannot identify with any of the objective evidence, very less. Some kind of EEG can do. But apart from that, the assessment is more of subjective, and even subjective patients will not be knowing how to express it. So you may only say, I'm not getting sleep. That's all. So to assess this, the assessment scales are the different things. So you have to take a lot of history. Okay, how you, when it is sleep is disturbed, and from how long, and all those things, and accurate history of any concurrent medical and psychiatric disorders. So we should see that any other medical or psychiatric disorders are associated along with the other thing. So this is a very important thing where the medical or psychiatric disorder also can contribute to the sleep disorder. And also, as I told, like evaluation of current medication. The medication related also could be there, which causes sleep, more oversleep, or insomnia, where you don't get the sleep at all. You have to see the medications also. So we can see that some medications you should not take in the evening, especially like CNS stimulants, or where the sleep is gone. And some medications are given in the night, like benzodiazepines, like alprazolamol, to get the sleep. Okay, so these current medications has to be evaluated. And also there are self-report, retrospective self-report, which assesses the different the quality of the sleep assessment, and making the classification. So one such like Pittsburgh sleep quality index, and also Epworth sleepiness scale, or insomnia severity index, also Berlin sleep apnea questionnaire. So if any one of you want to do any projects regarding doing this assessment of sleeps or anything like that, then this scales can be used, and they give a lot of scoring system, and based on the scoring system you can say that patient is having sleep disorders or not. So it's a prospective self-report. It's a split wake diaries or split logs also can be given. And behavioral measurements, that is actigraphy, is the one of the thing, how the person's behavior based on his sleep or not. You can see that some people who are not got good sleep, you may be very aggressive, and you may be very much not responding to the few things which is there. So, and polysomnography can also is one of the things, which consists of EEG, electrooculograms, electromyograms, EMG, and oronasal airflow, nasal pressure, rib cage. These are all the things which also assesses any other some nasal issues or oral issues are there to him to rule out anything. And rib cage and abdominal movement. Even if you say like while sleeping, the abdomen has to move. Okay, to the breathing. So if you have any kind of abdominal injury, also will leads to the decreased sleepiness. You cannot sleep. And also the oximetry. So this is the assessment for the PSC is one of the very important. We call it as gold standard for assessment of sleep. And also some functional imaging methods also are used, like you have PET, positive emission transmissions, and SPECT, single photon emitter, this one, and fMRI, that is functional magnetic resonance imaging. There are different methods also to see any kind of images of the brain and check that whether any issues is there in the neurotransmitters generations. Also, sleep disorders, they are classified, as I told, like into different ways. So one such classification is DSM-5. DSM-5, again, we seen like in the anxiety disorder
Sir,
also
your
we have.
voice is not clear.
Not clear now.
Yeah, now good.
Okay. So it's a diagnostic and statistical manual of mental disorders. So DSM-5. You can see that for all neuropsychiatric disorders, there is DSM scale. Even if for the anxiety scale, anxiety disorder also we have seen of the DSM scales. And there is also international classification of diseases, that is ICD-10, which usually helps in the more of the all kind of coding, and this one you can see this in the thing. And also there is also international classification of sleep disorders, which we say like ICSD. This is very specifically for the classification of the sleep disorder. The internationally this is done for the classification of the sleep disorder. Specifically, a type of sleep disorder is much more accurately is done by this classification. This is what we'll keep talking about the sleep disorders. So this is based on DSM-5 classification.
Suspect.
Okay, we'll just complete this last slide and end for the session. Okay, even my internet connectivity is not good. Can you hear now?
No, sir.
Cannot hear me?
Now,
Voice
sir.
is breaking, sir.
Yeah, I couldn't hear the last section, please, sir.
How about now?
No.
Breaking.
Now?
Okay. Now it's good.
Okay. Huh?
Now it's good.
Okay. So DSM-5 classification is very important. We will be in this chapter. We'll be talking about on all these terminologies. So the first one is the insomnia disorder. Okay, so I think more than getting sleep, not getting sleep is very important to consider, because it leads to a lot of the neuropsychological or physiological variations of the body. So insomnia disorder is the first one, where persons will not get sleep at all. Okay, and even if they get really less. So usually there is a say that okay, after going to bed, how long, at what time usually we should get to sleep after going to the bed? What is the duration, the onset of the sleep? Usually, the guidelines says that there should be at least an half an hour. Okay, it's not that going to bed immediately you go to the sleep. No one can. Only few instances it can happen. But at least after going to bed, within half an hour, if the person is not getting sleep, then we call it as insomnia. There is a issues in getting. Okay, so and also hypersomnolence disorder. It's again the more disturbances in the sleep increase the thing, and narcolepsy. And this is also an thing where you will not get much sleep, get disturbed sleep, and we'll see like many of the drug also will causes narcolepsy as their side effect. So it should be totally dealt with that, and lot of the surgical interventions, any surgical interventions also will lead to the narcolepsy. So here the next one is the breathing related sleep disorders. So you may get the sleep, but can say this is one of the very important things. Many types like
Sound is not clear, sir.
sound is not clear. Huh?
Voice is breaking,
Not
sir.
able to hear.
How about now? Are you all there?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Okay, the breathing related
Sir.
sleep disorders, we have again obstructive sleep apnea, hypopnea, where the breathing get obstructed here, and because of that there is a decrease in the breathing rate and reduces oxygen. Okay, and also central sleep apnea, where the brain get affected. It's a very dangerous thing. And sleep related hypoventilation. So for many people, they get into the sleep, the breathing rate decreases fully. Because of that, hypoventilation causes. So we'll see detailed in the few coming slides. And also circadian rhythm sleep wake disorders. This is one of the very important thing that happens for any kind of IT professionals. You know, like many people that field or even in some kind of industries, they have a week or 15 days shifts, morning and night. So during that time, you have the body will not get very much confused what time to sleep. Sometimes if it is a night shift, then morning person will be sleeping, and if it is morning shift, again night to sleep, it is becomes very difficult. Okay, so this circadian rhythm is also one of the problem. It occurs in the during very long journeys, the jet lag. You know, like traveling from one country to other, the timelines are different. Okay, so that's how it is usually occurs here. The circadian rhythm disturbances and parasomnias, where arousal disorders is so called as not rapid eye movement sleep arousal disorders. Many times in between the sleep, you're getting the sleep, but you're waking up very frequently. Also, the nightmare disorder, REM sleep behavior disorder. In this, there are two types parasomnias. And the lastly is the restless legs syndrome. This is also a part of the sleep disorder. Not much because of many concomitant diseases this may occur. Okay, so we'll stop here for this class. Okay, so any questions still here?
No, sir.
No, sir.
Okay, that questions you just prepare, and tomorrow I'll take the toxicology class, or so I'll be asking that toxicology related. Okay.
Okay,
Sure,
sir.
sir.
And who is presenting seminar this week?
Radhika.
Sir, me.
When you are presenting?
Sir, me.
Yes, you only when you are presenting.
Tomorrow, sir.
What time?
Today or tomorrow, for me, anything fine, sir.
Today you are there?
Shall I start? Yes, sir.
Huh?
Shall I start now, sir?
Now only.
Not now, sir.
You ask others also. When you are
Sir,
free.
you only tell, sir.
Huh?
I'm always free, sir.
No, others. Other classes are there.
Sir,
Sir,
not
I
now.
can't hear you, sir.
Sir, not now, sir.
So when you will have tomorrow?
Okay, sir.
Okay, sir.
Okay, sir, tomorrow.
Okay, sir.
Huh? Okay, I
Sir, can you
will.
tell me time, sir?
Huh?
Time, sir.
Tomorrow you'll start 10 o'clock. Any other classes are there?
Okay, sir.
No, sir, no class.
Is there, sir, Dean sir's class?
Dean Sir's PT3 class.
Tomorrow?
10 to 11, sir.
10 to 11.
Okay, 11 o'clock I will take class 1. Then later on you continue.
Sir, I can't hear you, sir, properly. Your voice is breaking, sir.
Tomorrow, 11 o'clock I will take class. Then after the class you...
11 o'clock, sir.
11 o'clock I will take class. Then you continue. Same like today.
Okay, sir.
Huh?
Okay, sir.
Okay then. Thank you.